Looking at the MCL, usually this is the result of injury to the MCL as a result of a severe blow to the outside of the knee. You can have a small grade 1 type of injury, which is just a straining of the fibers. Usually you can evaluate this because the patient will have tenderness medially along the MCL, not necessarily on the joint line, but along that MCL band. They have a stable valgus stress, no joint effusion, and they have some mild tenderness laterally, but a relatively normal range of motion. Management for these grade 1 sprains are pretty straightforward. Ice compression elevation for about 24 hours, crutches if needed. A lot of patients don't need crutches on these. Follow-up care with cryokinetics and exercise. Move from isometrics, straight leg raises, to bicycle riding and isokinetics. Return to play when basically they have no pain. Sometimes it takes about 2 to 3 weeks to recover from this, and that's just a grade 1 sprain. Grade 2 and 3 sprains. A grade 2 is a complete tear of the deep capsular layer. There are 2 layers of the MCL. There's a deep and there's a superficial layer. This is a tear in the deep layer. No gross instability with a stress test. They may have a little laxity, 5 to 15 degrees of flexion. So I mentioned before, no gross instability. So in full extension, they're stable, but you bend them a little bit and they open up a little bit. That means that the MCL is injured, but their capsule is intact. Slight swelling, moderate to severe joint tightness with decreased range of motion, pain along the medial aspect of the knee. Usually ice them, rest them, 48 to 72 hours, use crutches until the acute pain has resolved. Possibly a large brace. I usually always brace them in a hinge brace, just takes some of the stress off the medial side and allows the ligament to heal. Gradual progression from isometrics and functional progression activities. Now, grade 3, this is the actual, the pretty severe ligament injuries. This is the complete tear of the ligament on the medial side. It's a loss of stability, moderate swelling, immediate pain, followed by aching, loss of motion. Positive valgus stress test at 0 and 30 degrees of flexion, so they got a lot of laxity there. Ice compression elevation, conservative, non-operative versus surgical approach. Depends on the patient, depends on where the tear is, depends on the activity level. A lot of these tears, if they occur off the medial femoral condyle, there's good blood supply there, so you can actually brace them and they will actually heal that very well. If it is a distal tear where it inserts on the tibia and it's flipped on itself and retracted, a lot of times we have to fix those. So it depends on the type of tear. This is what a tear looks like in an MCL. This is a normal MCL on the right side, on my right side, I guess, here. You can see the tight fibers here. And then this is a torn MCL. All this fluid here is collecting where the MCL is torn. You can see it's torn off the femoral condyle. So this may actually heal because the fibers are kind of in that same area. Once swelling goes down, sometimes they'll lay back down and they'll actually scar up pretty well. This here is a tear that was actually retracted and flipped up on itself. We were already doing an ACL reconstruction. This is actually this is where the patella tendon graft was harvested from on the knee. So we had to do a medial approach here to actually fix this MCL. This is what it looks like arthroscopically. This is the medial femoral condyle here. This is the ligament actually had torn off and poked through the capsule here of the joint. So we actually had to fix that because the likelihood of that sticking down and healing back to the bone is pretty rare. Lateral collateral ligaments are strains on the outside of the knee, the lateral side of the knee, usually a result of a varus force coming from the inside to the outside of the knee. Direct blow is rare. If it's severe enough to damage, sometimes it can also cause injury to the cruciate ligaments, IT band or meniscus. Signs and symptoms are usually tenderness and pain over the lateral collateral ligament on the outside. Swelling and effusion are also common. Joint laxity with varus testing. And sometimes, like I mentioned before, you can cause injury to the peroneal nerve. Sometimes they either get directly hit by the peroneal nerve, sometimes it's a direct blow, other times it's coming from the inside out, and it's a stretching injury. So either way, you can have injury to the peroneal nerve where the patient will have a foot drop when they come in. So it's important to know the mechanism of injury, how they got hit, and where they got hit. ACL ligament sprain and tears. This usually occurs when the tibia is externally rotated and a valgus force at the knee, always from the outside in. Usually linked to inability to decelerate valgus and rotational stresses, and that's why you get a tear. It's more common in females as opposed to males, and that's usually due to the fact that there's some anatomic differences, such as notch size, ACL size, and laxity, as well as malalignments like Q angles They seem to be a little bit higher in females. That makes them a little bit more high risk for ACL tears. So extrinsic factors that can also contribute: conditioning skills, playing style, equipment, preparation time. We found that a lot of these ACL injuries can be prevented by having appropriate landing strategies and by doing things like sport-specific training, where you get the muscles to fire appropriately, things like plyometrics, and getting those fast twitch muscle fibers to fire appropriately and quickly when they're doing their twisting and turning and jumping activities will actually make a difference in preventing ACL injuries. We'll find more and more of that. That's why you're seeing more and more of these sport-specific type of facilities popping up all over the place. Signs and symptoms. Usually the classic symptoms, they feel a pop, they get a lot of swelling in the joint, positive anterior drawer and Lockmans. Management, usually go ahead and ice them, elevate them, put them in an immobilizer if they have some instability, to give them some stability when they're walking, give them some crutches. Usually an MRI is necessary. Arthroscopy can be necessary as well, but usually we start with an MRI just to confirm what's going on within the joint. Without surgery, back in the day, you used to say, okay, ACL tear, you're not active, you don't want to do any more sports, you don't want to treat it, we'll just rehab you and leave it alone. Well, now we're finding that a lot of these patients are requiring total knee replacements at an earlier age. And so because of the progression of arthritis, so there are actually studies now that support ACL reconstruction in older patients. That's anybody older than like 45 years of age. Obviously, if they're active, like I've seen patients that are in their 50s and 60s that still are out there playing tennis and golf, and they would still want to be active, they may have a little arthritis, those would be good candidates for an ACL reconstruction. As long as the arthritis is not severe. If the arthritis is severe and there's no joint space left, then obviously a total knee replacement is going to be a better option for those type of patients. Surgery may involve joint reconstruction with grafts, like we mentioned before. Requires about 4 to 6 months of recovery and rehabilitation. This is basically a basic MRI. I'm sure Dr. Fritz showed you these as well. There's an ACL ligament here. You can see the fibers very taut. There's no tear here. That's a normal ACL. Here is a torn ACL. There's nothing here. You don't see any fibers coming across. You see the PCL coming here posteriorly. There's nothing coming up in the front here. A lot of fluid and edema around the ACL. So that indicates an ACL tear. This is just an arthroscopic picture of an ACL tear. You guys saw the video earlier. This is what a normal ACL looks like coming across. You can see how fluid it looks, the nice fibers, and the ACL look intact. It's a torn ACL. A lot of times it just looks like somebody took a rope and split it in half and all these fibers just kind of flower out. That's what an ACL tear will look like. PCL tears, most at risk, usually 90 degrees of flexion. Most common mechanism of injury we see a lot of are dashboard injuries. A patient gets in a car wreck, their knee goes into a dashboard at 90 degrees of flexion, and boom, it knocks out their ACL. Sometimes it can also be somebody that falls on a curb, but it also can occasionally occur, particularly in athletes, from a rotational force. If they just get hit at the right position and they're rotating in the right position, they'll get hit. Kind of like Willis McGahee knocked out his ACL and his PCL and MCL when he got hyperextended or hit and he hyperextended his knee. So you feel a pop in the back of the knee, tenderness and relatively little swelling in the popliteal fossa, laxity with a posterior sag test, advantages with ice compression elevation, non-operative rehab of grade 1 and 2 injuries. Okay, so a lot of these PCLs will scar in. And if it's a grade 1 or 2 injury, we can just focus on quadriceps strength and let these actually scar in very well. For whatever reason, the PCL has a better vascularity than the ACL, and that's probably because you saw those vascular structures in the anatomy. All the blood vessels are posterior in the joint. So they probably have an easier time getting to the posterior cruciate ligament than they do the anterior cruciate ligament. That's why PCLs tend to scar and heal up a little bit better than ACL tears. So we actually can treat a lot of these PCL tears non-operatively. Occasionally we do have these the competitive athletes or elite athletes that have PCL instability. They want to get back to their sport, but they have instability. Usually if they've tried the immobilization for about 4 to 6 weeks, see if it heals, and they've done a little bit of therapy, and they still have laxity, then you can offer them PCL reconstruction. This is a PCL tear. Once again, looking at, here's the ACL, here's the PCL coming across. This is the PCL here torn. So you can see it here, and it's just kind of not It's actually in the grade film because you don't see it all the way over here, but you can see a lot more fluid and edema over here. This is what it looks like arthroscopically. This is ACL in the front, PCL in the back. That's a normal ACL-PCL relationship. This here is a reconstructed PCL. PCL has two bands to it. So this is the graft here. This is an autograft of the two bands here inserting into the bone. Meniscus. This is probably going to bump into, out of all these things, you'll probably see a lot of meniscus tears out there. Usually commonly injured due to ligamentous attachments and decreased mobility. Also prone to disruption through torsional and valgus forces. This is the medial side. It's more prone to injury because it's fixated to the surrounding capsule, so when you twist and turn, the meniscus may not move as much as, say, the lateral meniscus, which has a lot more play than the medial side. So the medial side would tend to tear more often. The most common injury is rotary force and with the knee flexor extended. You can have oblique, longitudinal, transverse type tears. It just depends on the type of tear, what the treatment method will be. Usually a patient will develop a fusion or swelling in the joint, joint line pain, tenderness, loss of motion, intermittent locking, giving way, pain with squatting and kneeling. Portions can become detached and cause locking of the knee. We get what's called a bucket handle tear of the meniscus, where the whole inner 1/3 of the meniscus is torn and flips up on itself, and it causes the knee to lock on itself. So a patient will come in with a swollen knee and they can't extend it. Sometimes you actually have to inject them with lidocaine just to kind of get them a reduction, to get them extended. Hopefully get the meniscus reduced back in its normal position. Those are a relative orthopedic emergency, just because you want to get these meniscus fixed earlier as opposed to later, especially if they're in a young patient and they're locked. Let's go ahead and go to the next one here. Some different ways that you can tear the meniscus. I've seen patients tear these just by kneeling down in a department store. I've seen patients tear them by getting out of their car. I've also seen patients tear them on the football field, the soccer field. There's just a number of different ways you can tear a meniscus, just depending on the position and the stress forces across this meniscus here. So this is a squatting mechanism here. It can cause a radial tear. This is the cutting mechanism, such as a blow to the lateral side of the knee, which can give you this bucket handle tear I was talking about. So this actually becomes detached. This inner third portion flips up and becomes unstable and actually causes the knee to lock. So as far as management, if the knee is not locked, but there are indications of a tear, you may have to get an MRI, okay, just to confirm this. If locking does occur, that's what I mentioned before. We sometimes have to do an injection or sometimes use anesthesia to kind of reduce the patient and get a reduced joint to make sure the meniscus sits back down in its normal position. With surgery, we do everything we can to preserve the meniscus. And like I mentioned before, there's certain tears that do well with repair. There's certain tears that don't. So it just depends on the type of tear that patient has, which will determine what the treatment method is. Meniscectomy rehab allows partial weight bearing and a quick return to activity. So if you take out a portion of the meniscus, those patients are recovering a lot quicker than a repair. If a repair, it's usually 3 to 4 months. And meniscectomy, which is a trimming, usually is about 4 to 6 weeks. These are different types of tears you see. This is basically these vertical peripheral tears here. There's a bucket handle tear that I was talking about before. That whole backside is torn. These we like to repair because it's in the blood. There's actually blood supply getting to that peripheral 1/3. These don't heal. We actually have to trim these back. These are flap tears or parrot beak tears. We call those parrot beak tears. And they can actually flip up like this and cause pain. And so the problem is that when this is torn, these tears actually wear down the femoral condyle, the cartilage here on either side, and can progress patients' arthritis. So it's never really good necessarily to walk around with a torn meniscus if you have a pristine cartilage like this patient did. So you can see here, after trimming it back, there's a little bit of blood supply there, but that's basically going right to that red-white zone where you're starting to see some blood supply. But they've got plenty of disc left, so that's why we did a meniscectomy. That was the video you guys saw already. Plica, it's basically an embryological remnant. That just means that it's something they were born with, that there's no real function to, but it is a lining of the synovium, and it can cause a thickened band on the inside of the knee. And the patients will come in, they have swelling in the knee. You may think they have a meniscus, but you push on the joint line and there's no pain. You do a McMurray's test, it's negative. They don't have any history of locking or instability, but they may describe a little popping and clicking on the inside of the knee. You run your finger over this medial femoral condyle and you feel a little thick band of tissue that is painful for them. That's a plica. Usually they can have pseudo-locking, like I mentioned before, where they feel a painful click, snapping and popping, pain with stairs or squatting. A lot of times an injection can take care of this, or an anti-inflammatory. Sometimes therapy can help as well, but most patients respond to conservative treatment with the plicas. It's just a matter of calming down the inflammation. Now, occasionally we can get these plicas that just don't go away even with injections, and we have to actually excise them and take them out. More than likely, they just are treated conservatively. Osteochondral knee fractures. This basically is the same mechanism of injury as collateral cruciate ligaments or meniscus injury, usually a twisting type of cutting maneuver or a direct blow to the joint. This just means that you have a joint, an injury to the bone and the cartilage of the knee, and actually can cause a detached portion of the osteochondral surface of the bone. The patient may hear a snap, feel giving way of the joint, swelling and immediate pain. Diagnosis is usually confirmed with an MRI. I mean, this is surgery for us, but like for you guys to be an MRI to confirm the diagnosis, see if they have a large flap or a piece that's detached. And the earlier we can get to these, the better, because we can actually fix these sometimes. Osteochondritis dissecans. This is something that occurs in kids and juveniles. We can't see them in adults occasionally. And all it is basically a partial or complete separation of cartilage from the subchondral bone. So what happens is that if you think of like a street, and the foundation of the street, like the formation of a pothole, sometimes the foundation softens underneath and all of a sudden the road starts to crumble and then you get a pothole. Same thing with osteochondritis dissecans. For whatever reason, the subchondral bone becomes weak or begins to necrose, and the overlying cartilage starts to detach or or collapse. And we still don't know the real reason it occurs. Some people think it's trauma. Some people think it may be endocrine abnormalities, or maybe anatomic differences. But either way, it's something serious and needs to be treated. Usually the patient will have aching pain, recurrent swelling, and locking. If they're very young, sometimes it's just a matter of casting them or immobilizing them to let it heal. But you got to recognize it and identify it to protect them, because otherwise they're going to keep doing their sports and activities and it's going to detach, and then it becomes a surgical problem. Other times we have to do surgery, usually in the older patients. Sometimes we drill them to stimulate healing, or pin the flaps in place, or even bone graft them. This is what an osteochondritis dissecans look like, or an osteochondral lesion. If you look at the knee, black, this is the bone is black here, the gray is cartilage here. You got this white areas, all this is edema and fluid all around this area, and you can see this big defect here. This is a detached osteochondral lesion here. That's looking at it from the side view, looking at straight on here. This is what it looks like straight on, and this huge fragment here is detached. So that can be a big problem in a young patient. So you want to identify it. This here is what it looks like arthroscopically. So the cartilage here is detached. This is just a little probe here showing you it kind of hinges open like a lid. What we do in this case, we hinge it open, we remove all this fibrous stuff and actually drill down into it, get some bleeding bone. We'll put some bone graft in there, sometimes from their tibia or from their hip, to actually plug it up a little bit and give it some vascularity to create some ingrowth in there, and then plug it in position with some absorbable pins. These are other techniques. If you have an older patient, let's say that's already had their chondral lesion flap deteriorate, and we can't fix it, and they have these large defects of exposed bone, we can drill small holes in them and actually create little marrow stimulation techniques where these actually create these fibrous fibrocartilage scabs in the joint. It's not cartilage itself, but it's very close to cartilage, and this is what it looks like on arthroscopically, multiple little drill holes there, and it'll fill in like a scab. But you got to protect these patients. They can't weight bear for like 6 weeks, because it's just like when a scab heals. If you cut yourself and you bleed, if you keep on wiping away the bleeding, is never gonna, it's never gonna really have a chance to heal up and scab. Same thing with the knee. If you keep weight bearing on this portion and you don't allow it to clot off and form an adequate scab that's mature enough to withstand weight bearing, it'll collapse and it won't do you won't have as good of a result. These are some newer techniques that we're doing now regarding cartilage regeneration, cartilage implantation. This is autologous chondrocyte implantation. We do this for larger lesions greater than about 2 centimeters, where we actually take this portion out where there is no cartilage left. We actually take a biopsy first of their cartilage here, send it out, get some cells of their own cartilage cells, inject it into this pothole here, and then sew a cover on top of that and glue it shut. That actually is shown to actually give us some pretty good results regarding these larger lesions that at one time we had no real treatment for. This is Oates procedure, where we actually take cartilage plugs from one portion of the knee and move it to another portion of the knee. This, I think, is more of a salvage procedure for me. I would try something like this first, just because these holes are pretty deep when you actually do these plugs in here. So I usually use this as a salvage if this ACI does not work. This is what it looks like here for an Oates procedure. The patient here, you can see the cartilage here, and you see this white area and then cartilage here. That's a big defect here in the cartilage chondral surface. Here's it arthroscopically. You can see the size of that defect, and these patients do well if that's the only lesion they have. So if you have a patient that's young and they have this one lesion here, we can actually plug that in and they'll do actually pretty well. If they have arthritis on this side, or they have severe diffuse arthritis on both sides of the joint, they don't do as well. And that's when we start leaning towards things like resurfacing or replacement. But when we have these isolated lesions like this, these cartilage techniques are actually very good. These are the plugs here filling in that defect. Loose bodies in the joint. Usually can occur, is usually chronic problems, usually occurs in patients with repeat trauma, such as repeat recurrent patellar dislocations. It can happen in patients that have osteochondritis dissecans because they have these cartilage flaps detaching, or meniscus fragments, or synovial tissue, or cruciate ligament fibers. Sometimes these can all cause little scar balls or little abnormal loose fragments in the joint, which can cause mechanical symptoms because they get lodged or stuck in the joint and cause the knee to buckle on them. If they're not surgically removed, they can actually lead to joint degeneration. It's back to that little pebble in the chute analogy. If you're walking around and you keep on stepping on that pebble, it hurts. Same thing with the joint. If you have these fragments that are floating around in that joint, like size of M&Ms, they're going to get stuck in there and they're going to wipe out your remaining cartilage. So this is the patient here that I had. You can see this large body here in the front of the knee. You can look at it from the side view here. And so we took that out. This is what it looks like in the joint. Something like this gets stuck in the joint, then it can actually take out a big chunk of cartilage and actually increase your risk of arthritis significantly. So we typically will take these out. Contusions or bruises, these are just usually, it has to do with any patient you get that has a direct contusion or bruise, particularly in the quadriceps. You'll see there's a lot of football players, obviously. Usually they present as a knee sprain, severe pain, loss of movement, swelling, discoloration. Sometimes they can have capsular damage in the knee if they just got hit in the right direction. Usually you treat this conservatively with ice compression elevation, gradually progress into normal activity following return of range of motion. Make sure they're padded for protection. Swelling doesn't get better within a week. You want to make sure that there's no chronic underlying conditions like a synovitis or a bursitis going on, because you need to treat them a little bit differently. Peroneal nerve contusion, we mentioned that before. These are nerve contusions, particularly on the outside of the knee. Usually they'll have a shooting nerve pain, the lateral aspect of the knee, numbness and tingling throughout that distribution of the nerve. Added pressure in this area will exacerbate the condition. Generally resolves quickly. A lot of times these neuropraxias or nerve bruises can resolve pretty quickly within a few weeks. But if it does not resolve, can it result in a dropped foot where they can't lift their foot back up. Ice compression elevation, return to play once symptoms resolve and there's no weakness, and they're able to lift their foot up. Padding for the fibular head is necessary for a few weeks because they're going to be very tender there. If they're going back to playing their sport, make sure they got a good foam pad they can put over that fibular head proximally, or the proximal fibula, to prevent that nerve. And sometimes if they do have a foot drop, you can give them an AFO, which is basically an ankle foot orthosis, which keeps their foot in a neutral position so they don't have a drop foot. And then if they do have if they're not responding to any of these treatments, then an EMG is necessary to confirm how bad the compression is, and sometimes they need a decompression, which is a surgical procedure.